Hey everyone, and welcome to The Explainer. Today, we're tackling something we see all the time in practice, oral candidiasis.
Okay, so here's how we're going to break it down. We're going to follow a path that looks a lot like a real clinical encounter, from figuring out what's going on all the way to choosing the right therapy and making sure it works.
So first up, let's get to know the bug itself. How does this thing, which is a totally normal part of our oral flora, suddenly decide to become a real problem for our patients?
You know, it's so important to get this first point straight. For most people, Candida isn't some outside invader that just showed up. It's a commensal organism. It's already there. The infection happens because the environment changed, giving it an opportunity to grow out of control.
This phrase just nails it, doesn't it? Oral candidiasis is a massive clue. It's a sign that the host's defenses are down for some reason. It's almost always more about the patient's underlying condition than it is about how strong the fungus is. So what's the takeaway here? We're dealing with an overgrowth. Our job as clinicians isn't to completely eradicate it. That's not the goal. The goal is to knock that fungal burden back down to a level that the patient's own immune system can handle again.
Okay, so what does this mean for us as pharmacists? Let's get practical and jump into assessment. We'll start with who's most at risk, and then look at what this infection actually, looks like.
And when you look at this list, what just jumps out? So many of these risk factors are tied to medications that we are dispensing every single day. We're talking broad-spectrum antibiotics, those inhaled corticosteroids for asthma, or even just dry mouth caused by anticholinergic drugs. Spotting these patients during a med review is a huge first step.
All right, let's talk about what this actually looks like. First up is the classic presentation we all know, acute pseudomembranous candidiasis, or, what everyone just calls thrush. You're going to see this most often in the very young, the very old, and of course, our immunocompromised patients. And here is the absolute key diagnostic clue, the thing that really helps you tell it apart from other white lesions in the mouth. These plaques can be wiped off. If you take a tongue depressor and gently scrape, they'll come off. And what's underneath is this raw red and often painful base.
But it doesn't always present as those classic white plaques, right? Let's look at another form, erythematous candidiasis. You'll often see this one pop up after a course of antibiotics, and it's also the most common type you'll find in patients with HIV.
So instead of white patches, think red and raw. For the patient, this usually translates to a pretty significant burning sensation, which can make eating and drinking really miserable. That loss of the little bumps on the tongue, the papillae, that can be another striking visual clue to look out for.
Now this next one, oh man, this is something you are absolutely guaranteed to see, especially if you work with an older patient population. We're talking about denture stomatitis. It's incredibly common.
And this is a huge opportunity for us to step in. A patient might not even mention it, because sometimes it's symptomless. But if they complain of any oral irritation, and you find out they wear dentures, you have to ask about their hygiene. This is so often linked to poor cleaning habits, a prime target for our counseling.
What you know is the perfect lead-in to our next section. Because honestly, before we even think about a prescription, our counseling is one of the most powerful tools we have to both manage this and prevent it from coming back. So check this out. 2 super common scenarios where we can make a huge impact. Got a patient using an inhaled corticosteroid? Simple advice, like rinsing their mouth with water after each use or using a spacer, can be a total game changer. And for someone with dry mouth, we can scan their med list for culprits and suggest easy fixes.
And for our patients with denture stomatitis, providing these clear, actionable steps is just as crucial as the antifungal medication itself. This isn't just about treating the infection they have now, it's about breaking that whole cycle of reinfection by getting to the root of the problem.
Okay, so we've counseled the patient, we've addressed the underlying factors. Now let's talk about the drugs. How do we pick the right agent to actually clear up the acute infection?
So which antifungal is the right call? This is obviously the big question. And really, the clinical guidelines make it pretty straightforward. It all comes down to the severity of the disease.
And this slide really lays out that main decision point for us perfectly. For a mild, first-time case, a topical agent like nystatin suspension, acting right where you need it, is often enough. But if it's moderate to severe, or if it keeps coming back, that's when you have to go systemic with something like fluconazole.
And this right here is where our expertise as pharmacists is absolutely critical. Fluconazole's drug interaction profile is significant. We're not just talking about a theoretical flag on the computer screen, this is real-world risk. We're talking about increasing warfarin levels to a point where a bleed is a real danger, or boosting statin levels and risking myopathy. It is on us to catch and manage this stuff.
So what happens when your patient isn't getting better on fluconazole, especially in a high-risk population? You've got to start thinking about refractory disease. This usually means we're dealing with a tougher bug, like Candida glabrata or Krusei. That's when we look at our next-line systemic options like itraconazole or posaconazole. But we have to remember the fine print, like itraconazole being a big no-no in heart failure.
All right, let's bring it all home. Let's talk about monitoring to make sure the treatment is actually working. And then we'll recap the biggest takeaways that you can apply in your practice tomorrow.
This is such an important piece of counseling. You have to set expectations with your patient. Tell them you should start feeling some relief in about 2 to 3 days. If they don't see any change by day 3, that's our signal that we need to reassess what's going on.
So I want to leave you with this final thought, something to keep on your radar. We all know that azole resistance is a growing problem, especially with some of these Candida species. So the big question for all of us is, as this threat gets bigger, how are our treatment strategies going to have to adapt in the coming years?